Hi everyone, I'm Brenna Lee. I'm a PhD student from the University of Toronto. I'm here to present our work, Constraint and Workarounds to Support Clinical Consultations in Synchronous Text-Based Platforms. Despite many aspects of our community returning to pre-pandemic times, recent studies show that virtual care is still a big part of our healthcare system. 35% of medical encounters are still done virtually. For many patients and physicians, this is often preferred over traditional methods because of convenience and accessibility. One form of virtual care is text-based consultations. Studies have shown that text-based consultations offer comparable medical benefits to phone and video calls, greater flexibility and access to care. Moreover, empowers patients to seek help for sensitive symptoms that they may be embarrassed about without the fear of being judged. Previous works have primarily focused on asynchronous text-based consultations. This is where a patient shows up, sends a message, and waits a while before they receive a response. This means that the response is delayed, but medical assistance is often time-sensitive. With the ubiquity of instant messaging, the possibilities of connecting with physicians are changing. We can have synchronous text-based consultations where patients and physicians will both log on at the same time, and when a patient sends a message, they receive a response immediately. This form of consultation is synchronous, and one of the main benefits is that the response is instant. The benefit of instant feedback means that there's a growing presence of medical platforms that provide secure and private solutions to conduct synchronous text-based consultations. And this is just a small subset of what is now available in the market in North America. However, research on how physicians are using synchronous text-based platforms is still lacking. Why is this important? Because physicians drive the consultation process, and implementing this technology without fully understanding how it's used can cause many usability challenges, and this is a cycle we've seen in many health technologies in the past. In this study, our main research questions on understanding how physicians conduct synchronous text-based consultations. More specifically, for physicians who are trained to conduct consultations where they can see and hear the patient, how does this synchronous text-based experience compare? What are some similarities, differences, workarounds, and opportunities? To answer these questions, we conducted a simulated consultation with standardized patients, also known as SPs. SPs are professional actors employed by many medical schools and have the training on how to act as patients. With the help of our medical collaborator, who's a physician, we came up with two scenarios. One, a patient coming in with UTI symptoms, and another, patient coming in with anxiety symptoms. SPs were instructed to act this out in a shy manner, but not withholding any information. This is to reflect a real patient encounter rather than what's often used for medical training. For our participants, we recruited 8 primary care physicians from the Greater Toronto area. There were 3 male and 5 female, all of them with at least 2 years of experience practicing since finishing residency. We told the physicians to imagine that they were working in a walk-in clinic and that they're seeing a patient for the very first time. The SPs and primary care physicians would then have a synchronous text-based consultation. Every physician saw both scenarios before we conducted a post-study interview to ask them about their experience. The entire study took roughly 1 hour to complete. You can find more information about the study in the paper. We coded up the conversation turns from physician participants and came up with 3 general categories for the content: question, empathy, and explanation. You can refer to our paper for more detail. On the right, we show that these can be mapped out across the entire conversation. Using participant 7 example, we see the combination of question, empathy, and explanation used to form distinct patterns that highlight the different phases of a medical consultation, which are gathering info, confirming diagnosis, and explaining treatment plan. All of this is to show that the content structure of the conversation is not that different from the consultation in real-world settings. Physicians are able to adapt to synchronous text-based modality without significantly impacting their workflow or ability to help patients. Moving on to constraints. We noticed that temporal constraints was often a problem expressed by many of our physicians. As participant 4 remarks, collecting information through text is just agonizingly slow. This makes sense. We know that typing is inherently slower than speaking. When we asked each physician to report on how long they usually spend on face-to-face consultations and compared to the time it took in our study, we found that it was 15 minutes versus 16.5. Of course, we need to take this with a grain of salt because the scenarios are simulated in our case, and most of our physicians have never used text to communicate with patients. But interesting for us is we notice that the difference doesn't seem to be that much slower. We were then interested to see what do physicians do to compensate for the slowness. We observed several workarounds, and one that we found particularly interesting is the use of double-barrel questions. You can refer to our paper to learn about other temporal workarounds. Here's an example of a conversation between one of our physicians in the UTI scenario. We have the physician asking, "Do you have to go pee more than usual? Is it more urgent? Any blood, any fever, nausea, vomiting, or back pain?" And all of this, by the way, was in one conversation term. And then we have the SP below trying their best to respond. "I'm getting to pee more than usual, but I wouldn't say it's urgent. No blood, fever, nausea, vomit, or back pain." As you can see, they even have a typo. Instead of saying having, they said gaving. In our informal chats with SPs, they said that this was a little overwhelming because there's just a lot of information and you don't know to miss anything. When we asked our physicians about double-barrel questions, all of them said this is bad practice and they would never do this normally. One of our participants even went on to provide some reasoning for why they think this happened. They said it might be because we know the patients can read the whole message multiple times and respond. Another type of constraint was nonverbal feedback. Normally, when doctors are conversing with patients, they will have them in front of them. They can see and hear the patient and vice versa. However, in the text environment, a lot of this feedback are removed. Several physicians were concerned about this. Participant Ace mentioned if this was in real life, they wouldn't know if this is the actual patient or somebody else typing for them. When there's a little bit of internet delay during the conversation, P1 was recorded saying, "Are they still there? Oh yeah, they're just taking time to respond." From a medical perspective, P3 mentions that a lot of the encounter is on the visual of seeing the patient because they use it to gauge how severe things are, whereas on text, you just don't know. To address some of these issues, we found that physicians would type out more verbal forms of acknowledgments. These acknowledgments fall under two forms, long and short. With long ones, we see them being used to summarize what's being talked about. As in here, from what I hear so far, it seems like you have a long history of on and off anxiety. Some examples of short acknowledgement include things like, "I understand," "I see," "okay." When asked if this is something common for them to say during consultations, many would say that this is normal. However, they're saying it far more frequently over text. As P7 explains, "Because if I didn't say this, it would be like I didn't really observe what the patient just told me." In terms of unique affordances, we observed quite a few, one of which is incorporating questionnaires. As shown in this conversation between P8 and our SP in the anxiety scenario, we see the physician jump directly into questionnaire, which is in this case a PHQ-9, a standard questionnaire used in many anxiety assessments. But as you can see, the SP was confused and did not respond the way physicians were hoping for. But this is also interesting for how smooth and natural it seemed from the physician's perspective. We did not prompt them in any way to use the questionnaire. But when asked about an interview, participants felt that a lot of what they were doing should be collected in a questionnaire. As shown by P2, who said, questions like, "Do you drink? Do you smoke? Do you do drugs?" etc., all of that, there's no benefit to me asking those questions. This is to show that questionnaires are an important part of many physicians' workflows, and it's natural to have them in the synchronous text-based situation as well. Another affordance we observed was the ability to support reflection review. During the text interaction, we saw a lot of our physicians scrolling up and down the chat window. When asked about this behavior, they said something like what P5 said here. "I'm just looking to see what I have already asked because I find my mind working at a mile a minute." Now, if we recall a quote we saw earlier on the double barrel slide for reasons why double barrel questions were asked, we see P3 saying something like this. "It might be because we know the patient can read the whole message multiple times and respond." This suggests that physicians perceive the ability to support reflection review is available for patients too, which allows them to ask questions in ways they would normally not do in person. Here are some key findings and design implications from a study on understanding physicians' use of synchronous text-based platforms. Through overall content structure, we found that there was no significant change in the workflow and it was relatively easy for physicians to adapt. However, there were many temporal constraints. It was often perceived to be slow, but physicians had workarounds such as double-barrel questions. Future designs can look at how we can help physicians parse out these double-barrel questions to make it easy to interpret. Another constraint is nonverbal feedback. Many physicians mentioned it was difficult to demonstrate active listening and had to provide more verbal feedback to compensate. Future designs can look at active engagement indicators to help physicians demonstrate active listening. Unique affordances include incorporating questionnaires and supporting reflection review. Future designs can look at how questionnaires can be easily incorporated into chats or ways to automate commonly asked questions. And this is our study on constraints and workarounds to support clinical consultation in synchronous text-based platforms. Thank you.